Everybody, it's Laurie White with the Greater Providence Chamber of Commerce, back with another edition of Chamber TV. This is episode number 147. And today we're talking all things healthcare. And we have as our special guest, Martha Wofford. And Martha is the relatively new, I say relatively because not all that new, president of Blue Cross and Blue Shield of Rhode Island, a very valued member of the Greater Providence Chamber of Commerce. And we're really excited to get to know her over the next 45 minutes or so and talk about some of the major issues here in Rhode Island that impact employers in the healthcare realm. So Martha, welcome. How are you today? Great to see you.
Thank you so much, Laurie, and thank you for the warm welcome and that you have extended as well as the rest of the community. It's just great to be here.
So fantastic. So I said relatively new. So tell us, it's been about 7-8 months, maybe?
7 months. Yeah, good math.
Okay, fantastic. So you have a very diverse background in healthcare, done a lot of different things, including some very specialty work on the kidney front. So can you just paint a portrait, if you will, of some of the key milestones in your career and what you're bringing to the table today at Blue Cross?
Yeah, absolutely. Well, I'll start a little bit at the beginning, which is I grew up outside of Boston. And then my career started in public service in the Clinton administration. And then I headed off to business school at Kellogg, and then found myself in New York City in management consulting. And then I was at Aetna for almost 10 years. I joined the company to help start up the Medicare Advantage business and had the opportunity to run different parts of the organization over the time there. And then I really decided that I wanted to shift to the delivery side. I wanted to be part of a really high quality care delivery organization. And so I headed out to Denver with my family, and I was there about 7 years. And I did lead different parts around value-based care, which I hope we'll talk about a bit today. Really this shift to how you focus on taking care of patients, of members, keeping people healthy and out of the hospital, and how that can create really great outcomes for individuals, but also savings for the whole system. So I did that for 7 years, as I said, and now had the opportunity to come back home to New England and to take the role at Blue Cross Blue Shield. So I am thrilled to be here. My parents are thrilled, as you can imagine, to have me back. Probably more importantly, my 15-year-old daughter, for them to be able to see her and spend time with her. And gosh, it's so fun to be in New England, to not be concerned when we wear our Patriots gear out that we're in danger. So it's really fun to be back in New England.
Okay, well, on behalf of all of us at the Chamber, welcome back to New England. And we're so thrilled to be able to have this opportunity to work with you and your team and continue the long-standing relationship that we have had with Blue Cross and Blue Shield of Rhode Island. We obviously were very happy and pleased and excited to work with Kim Keck over the years. And she, as your predecessor, has ventured off into Blue Cross and Blue Shield of America to take on the larger association role. So have you spoken to Kim? How's she doing out there? Any synergies that the two of you are working on that would put Rhode Island sort of in the spotlight as an innovation leader?
Yes, I actually was with Kim the week before Thanksgiving. So I was out in Chicago. We have an association meeting of all of the Blue Cross Blue Shield CEOs come together 4 times a year to talk about issues. And so it was great to see her, and she's doing great and settling into Chicago. And an area that I have a lot of passion around, and Kim shares, and many do, is around specialty pharmacy and what do we do about those rising costs. So I think that's an area that we will really push on. We may want to, I'd love to dive into that a little bit today if there's appetite. It's it gets a little bit complicated, but it's really an important driver of cost. And so for employers, here in Rhode Island to really understand more about what our options are to control those costs, I think is a really important topic.
Yeah, so let's go ahead and do just that. So we know that the major drivers of the cost of healthcare uh, in its totality would be prescription drugs as one, lifestyle issues, and chronic disease, chronic conditions. But I imagine that prescription drugs with specialty drugs as a subset of that, and the continued march for new therapeutics has really driven the cost of prescription drugs to a level that we haven't seen before. So tell us a little bit about that.
Yeah, you're exactly right. I can remember when pharmacy costs were about 5% of total healthcare costs. Now they're up to a third of all costs. So just tremendous growth. And really what's driving that is specialty pharmacy. And so when we say specialty pharmacy, I think people know, but these are things like injectables and oncology drugs, also rheumatoid arthritis, which we hear a lot about, many of us on the news. But this has gone up to be more than 50% of pharmacy spend is now with these sort of more complex, expensive drugs. And I think the thing that's really surprising to me, when we looked at our Blue Cross data, 1% of the pharmacy claims is 50% of the cost in specialty. So it's a very small number of patients, a very small number of these drugs being administered that are driving this incredible cost increase. And not only is it big, but it's just growing really fast. And so I saw the coverage last week about Humira, which again, many of us probably see ads for when we're watching sports and other things on TV. And Humira had a 10% price increase since last year with no changes to the medication. And so that was $1.4 billion in cost for the healthcare system in just 1 year incrementally. And so just as we think about that amount of cost, there's 4 more drugs that are going to hit in 2020 that are over $1 million price tag for each of them. There are 900 drugs in the pipeline. So as you think about this, is just exploding in terms of these life-saving drugs, which is important, but at a very, very high price tag, which is going to create real affordability challenges for us.
You mentioned it was 1%. That surprises me a little bit because with the prevalence of specialty drugs, I would have guessed that the incidence of individuals needing specialty drugs and being able to access them through their prescription drug plan would be more than 1% of the population. Did I misunderstand the ratios there?
No, you're right. Just 1%, just for specialty pharmacy. So again, there's different categories of drugs and some of the chronic conditions that you were referencing before as being a big area of spend. There's continued need for medications in those space, but we're talking about these specialty drugs, which are things like cell and gene therapy and require complex monitoring of patients over time and things. So it's a really small subset of the overall pharmaceuticals.
So you're not necessarily talking about the prescription drugs that we see when we're watching our favorite sports programs, but you're further defining it, more narrowly defining it to certain gene therapies. Is that right?
No, even like rheumatoid arthritis, like Humira is probably the biggest one that advertises is in that category. Yep. No, so it's again a small percentage of the overall claims, but it's a huge amount of the spend.
Yeah. So the drivers of that, so the pharmaceutical chains, giants, research labs would say, hey, for every one prescription drug that comes to market, there are 50 or 60 or 70 of them that fail, so we need to be able to recoup our R&D costs, and it's all part of the chain of developing new drugs, new therapeutics. Is there is that accurate? And is there another way to look at it? And is the FDA doing anything different today to sort of change the cadence of that?
Yeah, I think it's the right question. And I think we don't have the transparency to know if it's right or not right, because we just don't really understand the economics for the companies. But I think there's a path here. I have a lot of energy around what we think of as value-based care, of paying for outcomes. And one of the challenges for some of the new therapies coming to market is the outcomes are not clear. And so if we could enter into contracts to procure these drugs in a way that we paid for them if they delivered the impact, I think it would be a lot more palatable for all of us on the side of paying, whether that's an employer or an insurance company or the state or the federal government. And so I think we need to shift to that kind of value-based care arrangement to buy these drugs. And I think that's a big lever, right? When you think about what can be done, one is sort of purchasing, and how do you purchase a lot smarter? You can also drive to one therapy in that class as opposed to having a more open formulary. And so you're driving, and again, this might get a little too technical, but you're driving more of the volume to one drug that you can then negotiate around scale. And then if you can shift it to where it's more of an outcomes-based metric, then the way that care gets delivered to an individual today, you try lots of things, and then you may get to a drug that works. The goal here would be to be much more targeted and not take the patient through so many things, which is not good for the patient, but it's also expensive. And so if you can really fine tune the delivery and be more targeted, there's a way to do this in an affordable way, and then measure the outcome over time so that you're following that patient and making sure it's having the impact. And so I think there's a lot of opportunity to be smarter, but I think we all have seen the power of the pharmaceutical industry over the past few weeks with all the lobbying that's happened in DC for the Build Back Better bill, and whether the pharmacy reforms were going to be in the bill or not. As we know, the pharmaceutical industry spends more money on lobbying than any other industry in the United States. And so I think there's a lot that we collectively need to do to keep pushing back on fighting for transparency of what the pharmaceutical industry is doing, what pharma reps are doing right here in Rhode Island when they meet with physicians. What does that look like? How do we really have a better sense of the activity so that we can better manage it?
Yeah, so a very complicated equation, no doubt. And I can imagine, the angst that you and your colleagues at Blue Cross and other insurers across the country feel when you're presented with use cases from patients who need or believe that they need, or their doctors are telling them that they need to prescribe a certain set of drugs that could potentially change the trajectory of their life, their ability to survive a critical illness. So this strikes us as, really the question of the century, if you will, in terms of, how do we navigate through this?
Yeah, and one thing that we have been working on is legislation, how do we support that, where you could create some kind of a fund for what we think of as sort of these orphan drugs, because there's just so few people who are on them. So any one company, if they ended up with one individual, it could be really economically impactful for them. Can you actually pool those people together? So as a state, can we create a fund where we're all contributing, but it doesn't hit any individual employer or any individual line of business, but we then can go and contract with the manufacturers with that volume. So instead of, a company having one individual on a specific drug, you could look at where you'd have 100 in the state. And if you purchase together and manage those patients together, it would really smooth things out for employers, because the thing we hear the most about is that unpredictability and volatility being really, really challenging, especially for smaller businesses, but really for everybody in this time of economic distress. And so that we're looking at ways to create more predictability and do more balancing. So it's a shared issue, both in funding, but also in, again, sort of the pushback on pharma that I think we need to do.
Mhm. Now, would that be health insurance plan agnostic, if you will? So that would this pool of monies for orphan drug access be something that that all employers and all insurance companies would contribute to, so that it would be, you know, again, a larger umbrella?
That is the intent, is that idea of pooling with the state as well, so that we're all coming together and sharing the burden.
Yeah, so this is a very important topic, and one that, again, you know, if people are thinking about, well, what's, you know, what's really driving the cost of my health insurance plan, and what are some of the key factors? You point out that prescription drugs certainly are among well, among the top, you know, the top of the chain in terms of drivers. So the other two would be chronic condition and, you know, lifestyle. So where do the two of those issues fall in the pecking order from like an order of magnitude?
Yeah, so special or pharmacy is by far the number one now for us. And when you look, you know, there's been a shift from a policy perspective in the country. There's been this, you know, is end of life the most expensive, or are chronic conditions the most expensive? And they sort of gone back and forth in terms of, but they're both very, very expensive. There's a big opportunity on better management of chronic conditions and better preventive care, which is we're not really set up as a healthcare system to do that well. And so when I think about where we need to go, it's this shift from the sort of sick care system, right, where we get care, go to the doctor's office, go to the hospital when we need something acutely, to where we're partnering with our primary care physicians to take better care of ourselves. So that could be diet help, or making sure we have the right medications and are taking them. And so for physicians who are on this sort of 9-minute, you know, treadmill, if you will, of appointment after appointment, having the time to be proactive with us is hard. And so we'd really like to get to a place where a primary care physician has a set of patients that they're accountable for, and they get paid for them whether they come into the office or not. And then their goal is to try to keep them as healthy as possible. And they get paid every month for doing that. And it's not based on the activity or the email or the call they take or the office visit, but it's based on the actual health of the population. And so that's something that we think is very, it's a really hard shift from today's world. But if we can get there, it's so much better for the physician, who again gets sort of their schedules back, and they can take more patients on, which is such a problem for us here in Rhode Island, is access to primary care. And it's better for the patient because nobody wants to be in the hospital. It's better for the employer, right? Because you have a more stable, healthy workforce. Your costs are lower. It's better actually for the hospitals, because they can keep that hospital bed for the really acute situations, which actually pay them more, right? So it's like there's a way to make a win-win here, but it requires us all to come together and partner in a way that we don't really do today. And so it means us on the insurance side providing data to people delivering care, so they can see right there what's happening with the patient holistically in a way that's sometimes hard to see today. So there's a lot that we could do together, and I'm really excited about the opportunity to do that here in Rhode Island, where we're such a small state and we have the geographic proximity with Blue Cross. Our patients are really a big percentage of your average primary care physician's patients, right? And so the ability for us to really provide information could really change how that primary care physician sees their patients and change how they practice.
I guess I missed the fact that the window narrowed from 15 minutes to 9 minutes for a patient encounter. So very interesting that you would bring that up. So that leads me to another, tangent around post-COVID, although we're not even in a post-COVID environment just yet. But the notion of, virtual health, telehealth, these are issues that we, as employers, talk about quite regularly. Lots of legislation at the State House that would sort of, change the payment schedule for virtual health, telemedicine. So how do you see telehealth and virtual sort of encounters here to stay? And is that a good thing from your perspective?
I do see it as here to stay, and I do think it's a good thing. We need more access and more convenience in healthcare than we've had, and I think people have found that through telehealth. It's been really important on the behavioral health side. And as we think about the crisis that we face in the state around access, and adolescent is a particularly acute place. And so telehealth has been really helpful there, but it's not for every conditions. For sure, being seen by a physician, by a member of the care team, it can be really important in different situations. But I think it's a really big, maybe one of the silver linings of the pandemic is the shift to telehealth, and I do think it's here to stay.
What are your physician partners? How are they feeling about the advent of that? And do they believe that it helps to allow them to actually see more patients in a more effective way, or does it just add to the hamster wheel, if you will, if the cadence just gets even quicker and quicker and quicker if you're dispensing with the face-to-face and the friction that creates from a time perspective?
Yeah, it's a good question. My sense is that people are all over the board on that, and it has to do with part of its comfort with technology of the physician, but also the patient that they're seeing. And so, I've talked to physicians who are like, yeah, the patient couldn't figure out how to get the camera on them. So like, I'm looking at the ceiling of their house, and that's a hard telehealth visit. So I think for many, it's been really helpful because they've been able to keep people who are sick at home and take care of them and not have, I think we're all much more aware of germs, and hopefully one thing that comes out of the pandemic is we all stay home when we're sick. And so I think in some cases it's worked well, and for practices where the technology they already had and they were just then using it more, it was easier than for people for whom they had to learn how to do it. So I think it's been a little bit of a mixed bag on the provider side, but probably people are getting more and more comfortable. And so I think it's something that we can expect people to want to have continue.
One of the artifacts of the pandemic was the advent of online access to either the vaccine, the COVID-19 vaccine, and now sort of spreading into other vaccines. And I'm wondering, what we have, what responsibility we have as employers, and what you might have as a responsibility as a health insurer to help to sort of bridge that digital divide. And I think about how do certain populations that might not be facile with how to log on and set up an appointment to get their flu vaccine, or maybe some older folks, how are we going to bridge that gap going forward? Because it seems like that this is a development that is really taking off.
Yeah, I think it's a great question. Certainly there is some investment in broadband that needs to happen. I know that's part of the recommendations around some of the ARPA dollars. And so that would be really helpful, just so that people actually have the connectivity to make it work. And then I do think there's a lot of education of individuals. We did a program with some of our Medicare Advantage members where we gave them tablets and educated them. So some of this, like, how do you actually age in place, right? You're going to need the technology, and how do you go around? But it's real work on the ground with community partners to go and do that education, because it's sort of one by one, I think, to get people comfortable. So I think it's an important topic for us to work on as a community.
What are you seeing from your data about what patients are doing now to catch up on deferred healthcare, their own personal deferred maintenance? So we know during the COVID, the peak of COVID, that people were not doing elective surgeries. They were sort of doing whatever they could to stay out of the ER, even if it was to their peril, having a heart attack and just saying, I don't want to go to the health, I'm not going to the ER. I'm nervous about it. Knee replacement operations, so the whole thing of, procedures that might be assisting for your own well-being going forward and not doing them. Are you seeing that kind of those kinds of procedures coming back by looking at your claims? Where is the balance there?
Yeah, it's a really good question, and I would say it's just been quite volatile. And so it's been 2 years of up and down, and some of that activity has resumed. I think for any of us who've also tried to book appointments to do some of those procedures, it's been somewhat hard to get in and on the schedule. And so I think it's coming back to some degree, but not completely. Certainly pediatrics are very concerned about the drop off in vaccination for kids. I mean, that has been a really big problem. And so I think we're gonna see more acute cases of things like cancers that weren't caught because people didn't do the screening. So I do think that that's a risk and something that we're concerned about. And I know in some markets they are seeing much more of that happening, and we are starting to see it. But it's been very hard to predict. We have tried to encourage our members to get out there and do the preventive activity, the mammograms and the screenings and the things that are really, really important to make sure we stay healthy.
Interesting the way that sort of waxes and wanes. And I am hopeful. I think as employers have a role to play in keeping that conversation live among their workers, and sort of segueing into this to this mindset of the real role of the employer today, and what employers are wanting to take on in terms of being able to really work with their workforce and to use the clout of their purchasing power, if you will, to keep their workers healthy, both physically and mentally.
Yeah, I think it's very challenging to be an employer right now. Or I know as an employer, it's such a new environment. I think on the sort of morale side too, right? It's been such a roller coaster with the pandemic for all of us. And I think a lot about that, and how do we show up in a way that's empathetic and flexible, and how do we keep people healthy, and what does that look like? We have seen a real focus on wellness from employers, and an uptick in our wellness platforms. We've been doing a program with Small Group where members can earn dollars back if they participate in wellness activities, and the employers can earn back some of the premium dollars, and that's been really popular. It's paid out $1.1 million in the past year or so. So it's just like, this is something that people are doing. And I think another, just to the morale piece, the behavioral health side of this is really, really important for employers. We already had big challenges, for access on the mental health side in the state. And then many of those issues have been exacerbated during the pandemic. So I think really, how do you make sure that your employees are getting the access they need, the support they need? We have EAP lines, we have lots of different resources, and how do we connect people with resources to make sure people are getting the help they need? And staying healthy is a big challenge, I think, and important, and just, absolutely critical for all of us.
Yeah, that's a really good point. And we have partnered with Blue Cross and Blue Shield for, I don't know, some 26, 27 years. So the Chamber and Blue Cross on our worksite wellness awards, and events that really raise the awareness for employers around healthy practices, around new and novel ways that their workforce can take care of itself in a better way, and shining a spotlight on some of those practices. And we have done that again with great enthusiasm over a period of time. But during the course of the last year, in our recent work, we talked about the rich reservoir of information and benefits and tips and tricks and hacks and ways to approach the healthcare system that's available on your website and similar websites. And I think sometimes we, as just part of the insured population, we may not we may not realize the degree to which you can turn to a Blue Cross and Blue Shield and really dig down. And you're talking about the payout of incentive program monies for incentives for healthy behaviors, but there are so many things out there that people can take advantage of that they may not know about. Would you agree with that assessment? And what can we collectively do to sort of get people to to explore more in depth?
Yeah, I think it's a great observation. And for so many of us, it's so hard to navigate healthcare. It is so complicated. I know I struggle even to figure out, and I work here. And so I think we have tried really hard to have strong digital tools that people can access to then help them navigate. And we're continuing to innovate in the space to try to bring more resources to help people figure out, where do I go to get something done? What are the online resources I can tap into right now that can help provide me with support? We have this Smart Shopper program. We have a lot of different programs, as well as we have our retail stores, right? And so what's fascinating to me is that we're seeing many more employees come in. So people, who are employed and get their coverage from their company, come into your Blue stores around the state to get their questions answered. And so, they can come in and see a nurse case manager. They can get a question about a claim or a benefit answered. Some of them just come in for the community aspect, the cooking classes and that sort of thing. We also have yoga classes, which we have quite a few more seniors attend, because they tend to be, during the day. But we have some evening and afternoon ones as well. And so there is a way to, I think, tap into people who are knowledgeable, either online, on the phone, or in person, which I think can be really helpful.
Yeah, so kind of, attacking it from all angles, right?
Exactly.
And in person, I remember going to the opening of the first Blue store a number of years ago. And, the idea that, being a retail location, sort of, in your basic strip mall shopping center. But the key to that is that's where the people are, right? It's next to the grocery store. It's next to the bakery, et cetera, the gas station, the bank, so embedding in the community and saying, hey, we're here, come in. If it's digital access you're looking for, great, but there may be some value in actually having a face-to-face conversation with somebody who can help walk you through a problem.
Yeah, we find that particularly for members who speak Portuguese or Spanish, like the ability to come in and meet, especially in East Providence and other places, but the ability to meet with an associate from Blue Cross who speaks the language and can really help, it goes a long way. And then one thing we've tried this year is we have something called a fold out store, where we actually can move it around. And so it's cute. It's this little structure that we can put up on a truck and then move around to different locations. And so we've been sort of bringing that to the community versus having the community come to us, and just trying to see if that reaches some more people with questions. And that's been really popular. I was in West Warwick last week, and we had it outside a senior center, and it was just, just a steady flow of people getting their questions answered. And so I think that's also something we'll keep experimenting with and trying to make it as easy as possible to get questions answered.
Can you get a flu shot in this little pop-up fold-up?
Well, actually, so I'm so glad that you said that. We've done, as you I'm sure know, but a lot of great partnership with Lifespan around doing vaccinations, and we brought our Your Blue bus around and did all kinds of events where we went into the community just to make it easier. If there's any friction in terms of transportation or availability, how do we actually bring the vaccines right to the community? So that's something that we will continue to do and we think is really important.
Well, one side of the pandemic that's not all bad is it's really forced everybody, no matter what industry you're in, but particularly healthcare, to think differently about, how to provide services and how to provide access and do all the things that you're talking about that probably, weren't even anywhere close to being on the front burner before the pandemic, where everything is now up for grabs, right?
Yeah, I think that's absolutely right. From my perspective, the pandemic in some ways drove focus, right? We all try to do so many things and have so many priorities. And I think the ability to come together and all be really focused on the urgent issue and make progress has been dramatic. And so that's one learning for me. It was just, there's so many things. The other is this, I think what you're partly hinting at, which is the health equity issue, right? There's so much disparity out in the community. And so what do we do about that? And so we're, as you know, I think focused with Brown on the Rhode Island Life Index, which is a survey of Rhode Islanders to understand what are the perceptions of access to things that impact health. And what we find is that affordable housing is the #1 issue for the people of Rhode Island, where there's all these barriers and lack of access. And so that's an area where we've been working really hard to go and listen to the community. It's not a space we historically have been in. And so we need to learn a lot more about it. And then as we've been listening and learning, we've then been working with the community to act and actually invest to try to make a difference. And it's such a big problem that what we're doing, I think we've given $3 million to date. We just pledged another $4 million. It's probably just making a very, very small dent. But if we all come together and we work collectively, it can have a much bigger impact. And of course, some of the recommendations that came out of the work that the Rhode Island Foundation pulled together, recommend quite a lot of dollars going to affordable housing. And we think that's really, really important to be the foundation for a healthier Rhode Island.
We are talking to Martha Wofford, and she's the president and CEO of Blue Cross and Blue Shield of Rhode Island. We've been talking about all things healthcare, and I want to segue a little bit, Martha, and talk about some future tense issues, future looking, and some policy matters that no doubt are on your radar screen. And one of those issues, and you mentioned Brown, you mentioned Lifespan, is the potential consolidation of the Lifespan and Can New England systems. So curious to know what your current thinking is on the proposed merger and consolidation. We've been through this a number of times with those partners, mentioned, various iterations over the last, decade plus, but wondering if, in your view, the situation looks completely different this time around as a result of the pandemic, and are there other imperatives that are in play now that makes the proposed consolidation discussion look a little different? And how are you looking at this overall issue, and where is Blue Cross focusing its time and energy in terms of being able to help people understand what they should know about this?
Well, yeah, and I may not be the person with the best historical vantage point, so let me first acknowledge that. And then I also just want to start by thanking our provider partners for how they've shown up in the pandemic. It has been just heroic, the work that has been done by both the healthcare workers and the organizations. And I think people are really burned out, and they're obviously facing incredible challenges with workforce. So that's the starting point. Where we stand is that there is a lot of potential to improve how healthcare gets delivered in terms of the outcomes that we see. The quality in Rhode Island is kind of middle of the pack. And so we have a lot of opportunity to improve quality. And then cost, we have an affordability gap. And so we can see that. We can see healthcare costs going up at a much higher rate than wages. And so we have a responsibility, a fiduciary responsibility to our customers to really worry about cost. And so as we look at the merger, we see the potential on the quality side, but also the risk on the cost side that we actually aren't able to control healthcare costs over time, and healthcare costs going up squeeze out wage growth. And that's what I don't think any of us want. We want to have a vibrant economic recovery in Rhode Island. We want more jobs. We want wages to continue to increase and be healthy and have a really vibrant workforce. And so we see it as an obligation to really make sure that there are the right controls in place so that healthcare has that predictability that so many employers are looking for. And we can really look ahead to see over the long term how our costs going to be maintained. And so what I would say is we've been having conversations with the merged entities, and there's been some good conversation on quality, but there's just a lot more detail that we would like to see around the merger to make sure that that potential gets realized and that we avoid those pitfalls, and that we can actually over the long term have the right kind of accountability to ensure that the guardrails that get set actually are lived up to. And so again, we're ready to sort of dive into the details with partners, and just really eager to have the conversation get to that next level.
Yeah. So you mentioned quality is in the middle of the pack. I think that might surprise a lot of listeners to say, okay, we're in the middle of the pack. That doesn't square with what our general understanding is of healthcare in New England. We're in a very dense corridor of academic and medical institutions. Some of the best healthcare in the world is located, within this geographic region, in addition to, other places that in the United States that are really known for their academic affiliations. So could you tell us a little bit more about how you're looking at the middle of the pack measurement?
Sure. The easiest place to measure is on the hospital side, because those are published every year in terms of the measures. And so if you just look at the hospitals in Rhode Island, we have quite a few that have a C grade. And so that's not what we want it to be. We want it to be an A or a B, like we want for all of our kids. I think so. That's probably the easiest way to measure. And then I think patient experience, if you think about health equity and the disparities that people of color experience here, we need the patient experience scores to be higher, and we need them to be higher to start looking at them by race and ethnicity as well. So I think there's just, when we think about quality, there's things like hospital-acquired infections and things like those shouldn't occur. And so all of those type measures go into those hospital ratings, and there's just a lot of opportunity to get to the next level. And we'd love to help partner in whatever way we can on that, but certainly to see the plan of it takes a lot of investment and work to improve quality. It's a long-term journey, and so how are we going to get there is what we're really interested in hearing more about, and then seeing how we can be helpful.
One of the things that you and I have been discussing over the course of the last few minutes has been the changing role of the employer. And you've mentioned also the changing role and responsibility and the lever and the brute force of the insurer to drive change. So I'm wondering what you think the employer community ought to worry about and think about and prioritize in its looking at this issue, this consolidation of the two systems. What do you think the key drivers are for employers to really understand? And as you well know, this is the topic that everybody is talking about and trying their very best to think about it in a new and fresh way, and be cognizant of the tremendous fragility of the healthcare system, particularly here in Rhode Island, where we've got, systems, in very close geographic proximity to the north and the south, and the draining of, high level tertiary care potentially to other places. So what do we do to make sure that our own healthcare system, our own homegrown healthcare system, stays really healthy?
Yeah, I think it's a great question. And there is a lot of fragility right now when you look at the workforce shortages that the healthcare system is facing. And we're in the middle, I think, another surge here with COVID, and that's certainly concerning. And so I think it is something we all have to be worried about. I've shared this fact before, but what we see is that 92% of the care is happening in Rhode Island. So we're not seeing as much of that care going to other parts. Some of it, though, is oncology care. And so that's a topic to really think about. And I think how do we continue to create a really strong services here in Rhode Island is something that we're interested in supporting. So I guess for employers, I think we're at the point where we all should just be asking questions and trying to understand what's happening, what the plan is, and what does it look like over time. Because I think a lot about sustainable provider arrangements, right? So what does it look like for us to have contracts with providers that give them the wherewithal to be here in the future, but also to keep costs at a level that are sustainable for the employers, right? So that's the balancing act that we're trying to achieve. And so we really look out at the long term. And so as we think about the merger, there's the short term that might get discussed. And then we're really interested and concerned and want to make sure we have the right kinds of long-term infrastructure so that the employer who's trying to decide how many people to hire and what that's going to cost them over time can really predict and project that cost. And so I think we all have an obligation right now to just be interested parties in this, because it's really going to be important to our economic recovery. So I think that's the biggest role right now.
Mm-hmm. So you've talked about horizontal integration, but do you have concerns about the vertical integration that we're seeing now as well with the primary care practices and the centralization of that?
I don't know about concern. I am a huge advocate of the primary care physician as quarterback of care. I think I have seen PCPs who are really, really good at really managing every aspect of your needs. If you can walk in the office and you have a question where you can go get help right when you're in there, and they can bring the resources together, it is terrific. And so I would love to see more and more of that empowered quarterback of care, and thinking about how do we bring those sort of team-based resources to providers, because most are not going to have the scale to support that. So what does that look like? So I don't think it's necessarily any kind of an issue in terms of the vertical integration if it works together in a way to keep people healthy, right? What I think we all worry about is the amount of referrals to specialists that happen in the state. We have so much higher than anybody else in the country in Rhode Island in terms of utilization of specialist resources. We're 8th in the country in just the price. So just both the rate and the volume is really, really high. And so we have to figure out how do we enable primary care to take more holistic care of all of us, so we don't need as many specialists, and that has to sort of work together. So as long as the motivations and the contracts that we put in place and the incentives that we put in place reward physicians for doing that, then I don't think the environment that they're operating in is as important.
Yeah. I recall a number of years ago that our utilization of mental health was off the charts in Rhode Island compared to other places. Is that still the case, Martha?
It is.
Yeah.
Some numbers are 600 percentile of benchmark. It's so far different than other parts of the country. And I think we just have to sort of do what we can. Again, I think you can have primary care physicians who are more versed and comfortable in some of the diagnosis around issues that people are having, that can then get people help earlier. So if we get people to have more support earlier, then it can be less acute help. You need less inpatient beds for psychiatric services if you get somebody help long before they're in crisis. And so what we're really focused on doing is, how do you work with the community to create more community-based support? At times, how do you help support in the home? And so there's a huge opportunity, I think, to get to people earlier and open up more access. And then hopefully we'll start to see some of those numbers normalize.
Yeah, that's a great way to look at it. And those are very wise words. So we only have 2 minutes left, Martha. So I want to ask you, as we wrap up here, what would you say to employers? What do employers need to do? Members of the chamber itself, as a representative of the employer community, to really get more invested in healthcare and using, the leverage of the employer to help drive some of the metrics that, that we're talking about. What is the future look for that? And what would you offer as suggestions and guidance?
Yeah, I love that question. And I think a focus on wellness is critical. One thing we're seeing a trend of is employers starting to bring pharmacy and medical benefits back together again, because this issue of specialty care and specialty drugs moving around from the pharmacy side to the medical side, and being so core to how you actually take care of a patient who's got one of these really critical conditions. So I think that sort of ability to integrate care is a really important lever for employers. And then I think just partnering with us, we really want to help on getting to that stability and the predictability of costs. And so I think it's both, how do you lean in to support your employees and make sure they're getting the preventive care that we talked about, as well as mental health, and then really just let us know how we can be helpful, because we're stand ready to partner to try to help in the steps ahead here, because it is a really dynamic time. It's very hard for everybody on the healthcare side, the healthcare cost side, and on the employer side. So we are your partners, and really look forward to walking down that path with you.
Thank you so much, Martha, and thank you for spending such quality time with us this morning, talking through a lot of these issues. And again, we really value the long-term relationship that we have had with Blue Cross, particularly on the worksite wellness program. You have a great team, and it's great to welcome you into the community, and we look forward to chatting with you again. So let us know where we can be of value, and heck, maybe we'll just show up one of these days at your latest pop-up location and see what's going on. So
that would be great. This has been so much fun. Thank you so much, Laurie, for inviting me. I really appreciate it. And thank you again for the warm welcome. It's great to be here.
Thank you. Have a great day.
Thanks, you too.